Health students, here I will describe the achalasia. Pathology and Aetiology. Achalasia is derived from the Greek word khalasis, meaning failure to relax. This condition is uncommon, with a prevalence of 1.8 to 12.6 per 100,000 persons per year. The exact cause is uncertain but may involve loss of inhibitory ganglion cells in the myenteric plexus, potentially due to a virus-induced autoimmune effect. Muscle histology often shows reduced ganglion cells and chronic inflammation. Normally, food triggers primary peristalsis in the esophagus, and the lower esophageal sphincter, LOS, relaxes to allow passage. In achalasia, mismatched excitatory and inhibitory activity leads to failed loss relaxation and absent peristalsis. Over time, the esophagus dilates and empties incompletely, resulting in residual food and fluid, potentially predisposing to esophageal carcinoma. Chagas disease and Allgrove syndrome show similarities to achalasia. Clinical features. Achalasia typically presents between ages 30 and 60 with dysphagia, both solid and liquid, regurgitation, and heartburn, often misdiagnosed as GERD. Early stages may include chest pain/odynophagia. Patients often present late, adjusting their diet to maintain body weight. The Eckert score assesses symptom severity and treatment outcomes. Aspiration-related respiratory symptoms and pneumonia may occur due to food residue stasis, leading to fermentation and halitosis. Diagnosis. High suspicion is needed as symptoms are mild and chronic. Endoscopy usually shows frothy saliva pooling and food residue. The esophagus may appear dilated and tortuous, and the OGJ may appear tight and spastic but usually allows endoscope passage with gentle pressure. A normal endoscopy does not exclude achalasia. Barium contrast study shows holdup of contrast in the distal esophagus, abnormal contractions, and tapering stricture, bird's beak. Definitive diagnosis relies on high-resolution manometry, HRM. Treatment. The goal is symptom palliation, not reversal of neuronal degeneration. Therapies target the loss to reduce its contractility. Medical therapy. Limited to calcium channel blockers, nitrates, or 5-phosphodiesterase inhibitors to reduce loss pressure. Significant side effects make this option suitable for select patients only. Botulinum toxin. Injected endoscopically into the loss to paralyze the sphincter muscle, providing temporary relief. It is usually reserved for elderly patients with comorbidities. Pneumatic dilatation. A non-compliant balloon stretches the loss to disrupt muscle fibers. Serial dilatations show similar efficacy to surgical myotomy but carry a risk of perforation, especially with larger balloons. Heller's myotomy. Laparoscopic myotomy is performed on the lower esophagus and gastric cardia, often combined with partial fundoplication to reduce GERD. It is superior to single pneumatic dilatation. Now the latest treatment is biperal endoscopic myotomy, POEM. This involves opening the mucosa proximal to the myotomy site and cutting the muscle using endoscopic instruments. POEM is effective but has a higher incidence of GERD compared to Heller's myotomy. Esophagectomy. Reserved for end-stage achalasia with a grossly dilated esophagus. It is a last resort option due to its risks. Follow-up. Success is measured by symptom relief, quantified using the Eckert score. Patients should be counseled on a post-treatment diet as esophageal motility remains defective.